Am I live? Okay, yes. Okay. So hi guys, let's begin. Am I live? Yeah. Okay guys, so let us quickly begin. First, congratulations Indrani and Krishna and Aditya, the top three. Very nice guys and well done. So this was a simple undergraduate level immunohistochemistry quiz that can be
Can I close the
asked.
system?
Right. Okay. So coming to the first question on the screen, everyone. Yeah. Okay, perfect. So this was a patient. We'll quickly finish it up so that these are most tentative questions which can come from IHC guys, and they were based upon some previous year questions and some important topics that can be asked to an undergraduate and must to be known by an undergraduate, right? So let's start. Okay, so this is a patient who has a mass in lung, and to find the primary of unknown origin, IHC was done. So IHC, one of the very important use of IHC is to identify the origin for primary of unknown origin. And please remember, CK7 and CK20 are one of the very important questions. Remember, CK7 and CK20 are cytoplasmic markers. So you all should remember this chart. Everybody, I am sure you remember this. So remember, divide your body over the colon. Everything over the colon is 7 positive. Okay? And below the colon is colon 20 positive. So anything over breast, lung, thyroid is CK7 positive, 20 negative. Sirf 20 positive is your colon cancers. Okay? So colon cancers are 7 negative. Now both positive, B for both, it is bladder. Okay? So bladder is positive. Apart from that, ovarian mucinous carcinomas are also both positive. Please remember that. And both negative are those cancers जो कि धोखा देते हैं सबको. Okay, so they are the betrayal cancers because hepatocellular and renal cancers, they are carcinoma. Okay, so every carcinoma has a rule that it will spread through lymphatics, but these are two betrayal cancers. Why they are called betrayal cancers? Because they spread by veins. Okay, so hepatocellular carcinoma and renal cell carcinoma prefer spreading by veins. So they don't follow the rule of carcinoma. So they are 7 and 20 negative. Apart from that, prostate and squamous cell carcinomas are also 7 and 20 negative. Okay, so that's a basic chart you have to remember. So that was given 7 and 20 positive. So it has to be a bladder cancer. Okay, so the answer was A, and most of you marked it correct only. Okay, carcinoma prostate and renal cell carcinoma 720 negative, and colon cancer is CK20 positive. That is what you have to remember. Okay, so that is the important of carcinoma of unknown origin. Okay, right. Going to the second question. So this was your image of the immunohistochemistry that was given, and this is basically, what is this called as? What are we doing here? So this is called as molecular profiling of breast cancer. Please remember, everybody, molecular profiling of breast cancer is always done by gene expression analysis. So how does IHC help? This is the surrogate panel. Okay, so this is the surrogate panel. I hope everybody knows how do we classify the molecular classification of the breast cancer. The recent update I'm asking about, I posted on the Instagram yesterday. So I hope everybody remembers that we have luminal type of breast cancers, we are HER2 new enriched, and we have triple negative and Claudin low. These are the 4 groups we have. So everybody knows luminal type of breast cancers are usually ER and PR positive. Okay, so luminal type of breast cancers are ER and PR positive. And these cancers which are ER, PR positive, luminal cancers, are further divided into 2 types, luminal A and luminal B. So क्या difference होता है? Luminal B also has HER2 new positivity. So they are now if you look at the classification. Okay, so let me just tell you. So now if you look at the classification, here, so we have luminal, HER2 new, and triple negative. Now luminal cancers are further divided into luminal A and luminal B. Luminal B is HER2 new positive, and they are further divided into HER2 new positive and HER2 new negative types. So this is one thing that everybody should be very clear with, and this is the molecular classification which you should remember. Please remember, somebody can ask you which is the triple positive cancer. They are luminal B type cancers. Okay, everybody should remember. And which type of cancers are luminal B type? They are type 3 lobular carcinomas. I've written here luminal A cancers कौन-कौन से होते हैं? They're usually mucinous, lobular, and tubular. So these variants are luminal A. Luminal B कौन सा होता है? Grade 3 lobular. Okay, so high grade lobular cancer is usually high proliferating. So luminal B means proliferation is higher. So grade 3 lobular carcinomas are luminal B. HER2 new enriched कौन से होते हैं? Apocrine and micropapillary are HER2 new enriched, and these usually have p53 mutation inherited. That is germline p53 mutation. That is, they are associated with 𝗤𝗂𝗏𝗀 syndrome. So if you have somebody ask you 𝗤𝗂𝗏𝗀 syndrome के साथ कौन से breast cancers associated होते हैं, they are always your HER2 new enriched type. Okay, whereas somebody asks you triple negative cancers कौन से होते हैं? So triple negative cancers are either medullary or metaplastic. Okay, medullary or metaplastic, and one more secretory. Okay, so medullary carcinomas are usually associated with inherited 𝗣𝘂𝗶 mutation, but it can also be acquired 𝗣𝘂𝗶 mutation, that is hypermethylation. Okay, so these are triple negative cancers. Please remember acquired p53 mutations. Okay, so acquired p53 mutations are usually associated with triple negative. Okay, so remember this question. Please don't do this wrong. Somebody asks you germline p53 mutations. They are associated with HER2 new enriched. Acquired p53 mutations, okay, that is sporadic, are usually associated with triple negative breast cancers. So that is one thing which everybody should be very clear with. Okay, so now this was the image that was given to you. Now let's come back to the image that was given to you. So this was the image of triple positive. Remember, ER and PR are coming in the nucleus. They show you nuclear positivity, whereas membranous positivity is very typical for HER2 new. Okay, membranous positivity is typical for HER2 new. And if you show all the three are positive, then it is your luminal B cancer. Okay, now what is claudin? If somebody asks you what is claudin low cancers, so claudin low cancers are those cancers which show you markers associated with epithelial mesenchymal transition. Okay, so tumors which are associated with epithelial mesenchymal transition are usually claudin low type. Okay, so that is one thing that everybody should be very clear with. Okay, so that is your breast cancers. Please remember वो कौन सा ऐसा okay, so we'll talk about it. So this is HER2 new. So HER2 new, whenever it is too positive, we have to do FISH in that. Okay, to analyze whether the gene is amplified or not. Okay, coming to the question 3, which of the following is required for brown color on immunohistochemistry? What is the answer? It is diaminobenzidine, very popularly called as DAB. Okay, what is this? Fluoroisothiocyanate and phycoerythrin. So these two are basically used in your flow cytometry. They are used in your flow cytometry. Apart from that, FITC is also used in immunofluorescence. Okay, where do you use diazo reagent? Diazo reagent is used for bilirubin estimation. Okay, so it is used for bilirubin estimation. That is what you all have to know. Okay, now coming to this, an undifferentiated tumor is seen on biopsy. To confirm this is an epithelial tumor, which IHC should be done. So everybody should know it is an epithelial tumor. So remember your intermediate filaments, we should remember here. So remember the rule of life. Epithelial tumors होते हैं हमारे पास और mesenchymal tumors होते हैं. Okay, so that is what you should remember. Epithelial tumors are always positive for cytokeratin. So whenever we have a poorly differentiated tumor, we have to identify it with cytokeratin. Whenever we have a mesenchymal tumor, okay, it is usually always vimentin positive. It is usually vimentin positive. Please remember, everybody, if it is a skeletal muscle differentiation in the mesenchyme, then this will also be positive with Desmin. This will also be positive for Desmin. Okay, so that is one thing. So somebody gives you a question, and this was also a repeat question. Patient presents with embryonal rhabdomyosarcoma. Which mark IHC you will put for this? It is Desmin. Okay. NF is neurofilament for the neural differentiation. So this is what you all should be knowing it. Okay. Now coming to this, which many of you marked it wrong. So let's come to this. So this is a 60-year-old female presents with breast lump. On IHC, tumor was 2+. So whenever it's 2+ IHC positivity for HER2 new, we have to do FISH to identify the EGFR amplification. So please remember, everybody. So EGFR is the gene. Okay. So this is EGFR gene, especially beta-2. Okay, and it increases the proteins, which is your HER2 new. Okay, so either you detect the proteins HER2 new on the membrane, okay, or you have to detect the gene amplification. So most of the time, when it comes completely on the membranes, it is 3+, or it doesn't come, it is 1+. 2+ is an equivocal case. In that case, we have to directly go and see the gene. Now, what is the rule of the law? Look at this, guys, which you were saying amplification here. So normally what do we do is, remember in the question, they will always give you the colors. Okay, so it's HER2 neu is with the red color, and this probe, centromeric probe for chromosome 17 is the location for HER2 neu. It is with green color. So we should see 2 for everything. Okay, so 2 green and 2 red should be seen. Okay, 2 green and 2 red should be seen. Now, what is happening in this case? So in some cases, you are seeing this one, like this one, you are seeing 3 copies here. Okay, so is this amplification? No, guys. The rule is that whenever HER2 neu to CABP should be more than 2.2:1. Okay, so that should be 2 times more. Okay, so yani ki 4 se zyada signal hone chahiye. It should be 4 or more signals. Okay, so more than 4 signals should be seen. So this is not amplification. How does an amplification looks like? So look at this. This is what is an amplification. It should be at least more than 4 signals, more than 2.2 signals. Okay, then only it is considered as positive. Look at this. So there are 2 green signals, and for that 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, like that. So you have to be very, very clear. Okay, so only 1 or 2 positive does not give you amplification. For amplification, the positivity has to be more than 2.2. Okay, so अगर 1 copy of CPP आप centromere probe of 17 ले रहे हो, तो you should have more than 2.2 copies per 1 centromeric probe. समझ में आई? Otherwise, you will not call it as an amplification. Okay, so that is why I purposely gave this question to make you understand that you have to understand this. Okay, right? So that is your amplification. Only 1 or 2 signals देखकर amplification नहीं बनाना है. Okay, so that's important point. Okay, now coming to the next. Everybody is clear with this? Anybody having any doubt? Right? Okay, perfect. Thank you, Kartika. So 67-year-old male presents with mass in the lung. The tumor showed following electron microscopy. What is the IHC marker that will help in confirming the diagnosis? Please remember, these are long and thin microvilli which you are seeing. This is your mesothelioma, and you know mesotheliomas are positive for calretenin. Okay, calretenin is a marker for mesotheliomas. Okay, now please remember here that whenever we talk about synaptophysin, this is the marker of neuroendocrine differentiation. So small cell carcinomas can be synaptophysin positive. So look at this. This is the IHC markers which you should remember. So whenever we're talking about neuroendocrine tumor, this is your chromogranin, synaptophysin, CD56, and INSUM. Okay, INSUM 1. Okay, so this is your markers for neuroendocrine, and 𝗏𝗶𝘀 also they can give you. So 𝗏𝗶𝘀 is also for neuroendocrine differentiation. Okay, squamous cell carcinoma is P53 and P40. Mesothelioma is calretenin and WD1. Lung adenocarcinoma, this was your NEET PG question this time. Please remember napsin and TTF1. And intestine, this was your INI-CT question last time. Intestine, what is the marker of choice that you should use? This is CDX2. Okay, so CDX2 is a marker of your intestinal tumors, colon cancer. Okay, so that is the just IHC markers that I put in a chart because these are repeatedly asked questions. Okay, apart from that, you have to remember there are other markers for mesothelioma also. Apart from calretenin, it is CK56 positive, WT1 positive. At least itna to yaad rakhna hi hai aapko. Okay, apart from that, you have to remember which is the virus which is associated with mesothelioma. It is SV40. SV40 is the virus which is associated. What is the gene of mesothelioma? It is BAP1, that is BRCA associated protein. So BAP1. Okay, and remember always, this is a very, very frequent asked question. Hamesha baar baar aata hai. What is this? Please do not miss this. These are asbestos body. They are dumbbell shaped bodies. They are usually translucent clear. Okay, please remember that. And usually after a point of time, iron will be deposited over this, and then they will become brownish, golden brown in color, and then they are called as ferruginous bodies. Okay, so that is about mesothelioma. Remember, what is the latent period? Once today, if you are exposed to asbestos, mesothelioma develops after 25 to 40 years. That is the point that you all should be remembering. Okay, so this was another question. This is a repeat INI-CT question. So what is a nuclear neuroendocrine marker? Everybody knows INSUM is a nuclear marker. Synaptophysin and chromogranin usually comes in the cytoplasm. CD56 comes in the membranes. Okay, so this is a nuclear. INSUM is a nuclear neuroendocrine marker. Please remember, this is a very, very important table that I have just made it for you. So what is this? So if you talk about neuroendocrine tumors, what are the neuroendocrine tumors of your body? We have pheochromocytoma, neuroblastoma, paraganglioma, carcinoid, small cell carcinoma of lung, medullary carcinoma of thyroid, and Merkel cell carcinoma. So to start from the top, in this skin, we have Merkel cell carcinoma, which is a neuroendocrine carcinoma. Then come below to thyroid, we have medullary carcinomas. Okay, come to the lung, this is small cell carcinoma, then carcinoid, paraganglioma, neuroblastoma, and pheochromocytoma are 4 together. Now, all of them show you very characteristic features, same IHC and same electron microscopy and same light microscopy. So they have salt and pepper chromatin. That's a typical chromatin of neuroendocrine tumors, and it's a repeat question. IHC marker of the neuroendocrine tumor is also a repeat question. बार-बार पूछा जाता है. An electron microscopy of the neuroendocrine tumor, again it is asked again and again and again. It is dense core granules. Okay, please remember the concept of 𝗪 which is seen in paragangliomas, guys. So what are paragangliomas? So paragangliomas can be intraadrenal or extraadrenal. Intraadrenal paragangliomas are pheochromocytoma. Extraadrenal paragangliomas are like carotid body tumor. And what is 𝗪? That is their nest of tumor cells, and they are surrounded all together by the group of sustentacular cells. Please remember, the sustentacular cells are S100 positive. This is a point that everybody should be knowing. This is a very simple gist of neuroendocrine tumors, which everybody should be clear, and it's asked again and again and again in exam. Okay. Okay. Now, next question was, which of the following neoplasm typically shows you positivity for CD30? So remember, guys, I didn't want to complicate the question. Remember, CD30, if it is coming in the Golgi zone, okay, that is very, very suggestive of Hodgkin's lymphoma. So classical Hodgkin lymphomas are usually, Hodgkin lymphomas are present in the Golgi zone. Okay. Otherwise, CD30 positivity is also seen in embryonal carcinomas. Okay, it is also seen in embryonal cancers. Apart from that, this is also seen positive in ALCL, anaplastic large cell lymphoma. So if somebody gives you where all are CD30 positive, please remember embryonal cancers, ALCL, anaplastic large cell lymphoma, which usually has translocation 2-5, and they show you very typical cells called as hallmark cells. Okay, they show you hallmark cells which have horseshoe nucleus. Okay, and classical Hodgkin's lymphoma. Okay, so that is what you have to be very, very clear with. Okay, so that's the positivity for that's the answer for your CD30 positivity. Now, coming to the next question, this is another question. Can you see the positivity? This can be given to you as an image-based question also. This is the nucleus. On both the side of the nucleus, you can see these dots. Okay, you can see this dot. Appreciate this dot just around the nucleus. This is called paranuclear positivity. So paranuclear positivity, when they are giving you, this is very, very suggestive of Merkel cell carcinoma, especially if it is CK20. So CK20 dot-like paranuclear positivity is very typical of Merkel cell carcinoma. Please remember, Merkel cell carcinoma is a neuroendocrine carcinoma of the skin. It typically occurs in elderly, and it is very aggressive tumor. Okay, and they will typically show you CK20 dot-like positivity. Okay, that is what you all have to remember. Apart from that, what is the marker for melanoma that you should remember? It is HMB45 and S100. Can anybody tell me one more tumor which is HMB45 positive? Please remember this here. Don't forget, it is �11. Okay. So this is �11. Okay. So this is perivascular epithelioid cell tumor. Okay. So that is �11, perivascular epithelioid cell tumor. And please remember, whenever we talk about �11, there is a tumor called as sugar tumor, which occurs in the lung. So �11 of the lung is called as sugar tumor. Please remember that. Sugar tumor is a �11 of lung. Okay, so they are all HMB45 positive. So HMB45 is positive in melanomas and �11. Please remember, this is a tumor which arises from perivascular epithelioid cells. Okay, right. So that is about this. Yes, very good, Satvik. You get full points on that. Angiomyolipoma is a �11 of kidney. Okay, so these are typical tumors which are seen with tuberous sclerosis. So angiomyolipoma is a very typical tumor which occurs in tuberous sclerosis. So tuberous sclerosis is associated with very unique tumors, like in lung, like in heart, it is present with rhabdomyoma. So anybody who can tell me what are the cells which are seen in rhabdomyoma? Quick, what are the cells which are seen in rhabdomyoma? Quick, let me see who answers this first. Okay, so it is spider cells. Okay, so these are spider cells. So spider cells क्यों होते हैं? क्योंकि there is a lot of glycogen. So that is why the cells separate from their margins. So these areas appear clear. Okay, that is why they appear like spider cells. So the spider cells are seen in rhabdomyoma of the heart. And whenever you have rhabdomyoma of the heart, please remember it usually occurs in the children and it is seen in the ventricles. So this tumor is seen in ventricles. In contrast to myxoma, which is the most common tumor of the heart, and it occurs in the atria. Please remember. Very good, Kartika and Satvik. Okay, perfect. Now, this is the last question of the day, and I hope I have finished on time and I have not wasted your time. What is this technique shown? So which technique is this? Okay, is always asked in exam. So this is which technique? So what catches your eye? This is your antigen, and to this antigen some antibody is associated. To this antibody, another secondary antibody is associated, and then there is this long structure here. This is your polymer. Okay, so this is your polymer which has a lot of peroxidase in it, So this method is called as polymer method of immunohistochemistry. Okay, so this is the most common method for immunohistochemistry which we use. Okay, in earlier days we used to use Wiedin-Biotin method. Okay, so this is the earlier method. Wiedin-Biotin method of IHC was done earlier. Okay, or peroxidase anti-peroxidase method was also done. Okay, peroxidase. But what was happening was the binding was not complete. So now they started using a polymer जिसके ऊपर सारा peroxidase लगा होता है. So what happens is as soon as the antibody, okay, whatever is the target desired antigen, we bind the antibody to it, and to that we add the polymer which has peroxidase with the secondary antibody. And what happens is all the markers join together and they give you a beautiful brown color when tagged with dab. So as soon as you put dab on it, they will give brown color. So the sensitivity of the technique is increased because peroxidase immediately binds and gives the color, brown color. So that is why इसको polymer method कहते हैं. ये सबसे अच्छा method है अभी IHC का, क्योंकि it is very very specific and it gives, there are no unbound molecules which are left. So it quickly binds and it gives a very strong brown color positivity. Please remember, when they will give you flow cytometry, they'll give you like this, equipment like this, in which the molecule is passing and it is scattering in two directions. Okay, so that is flow cytometry. Cytogenetics, you know that they are arranged like chromosomes arranged in the decreasing order of length. And PCR, जब भी देंगे तो they will decide the technique. They can give you Sanger, which is a repeatedly asked question. Please remember, what is the methodology of Sanger's PCR? This is chain termination method, because we add DD-NTPs. Okay, dideoxy NTPs डालते हैं जिससे कि chain terminate हो जाती है. Okay, so that is for Sanger techniques. Okay, so Sanger technique can be given. So these are 4 common techniques which can be given to you in exam to identify the technique. So this is IHC, which I've shown you. Primary antibody, secondary antibody, tagged to polymer. Okay, flow cytometry, light scattering in 2 directions. Cytogenetics, chromosomes arranged in decreasing order. By the way, what is the fixative of choice for cytogenetics? Who's going to tell me that? Karyotyping. What is the fixative? Yes, what is the fixative for karyotyping? Quickly. Yes, it's Carnoy's fixative. Perfect. Okay, so PCR is Sanger's. So these are 4 common techniques that can be asked in exam. So with that, we finish this session, and I'm sure you would have learned something from this session. Please let me know how did you find this session. And very good, Karthik. So with that, we finish this session. Any doubts anybody can ask me now. And if you would like to have more such sessions, please let me know. So yes. Okay, so that is it about it. So anybody who wants to ask anything? Yes. Thank you, Chota Doctor. But what is your name? You should tell me that. Thank you, Satvik. You are perfectly correct with that. Satvik, ये बताओ sacchamanofixative कहाँ use होता है? Who's telling me that? Sacchamanofixative. So Carnoy fixative is methanol and glacial acetic acid. Where do you use sacchamanofixative? Yes, sacchamanofixative is used in sputum cytology. Okay, so why? Because it has carbovax. So what happens? Sputum is very thick, isn't it? It has very few cells. So you add this sacchamanofixative, which has carbovax. So this carbovax goes and supports the cells. So when you are trying to, dissolve the mucus of the sputum, these cells are supported by carbovax and they're not lost. That is why sacchamanofixative is used in sputum, and it can be used in any specimen which has a lot of mucoid substance. Okay, so it can be used in any mucus. Very good. Saliva also you can use it. So that is your sacchamanofixative, where a lot of mucus is there. So to protect the cells from getting lost, we add sacchamanofixative. Okay, so the purpose of sacchamanofixative is to protect the cells, because carbovax hota hai uske andar, it has ethanol with 𝗗𝗂𝗶. Okay, so ethanol is a fixative, and the 𝗗𝗂𝗶 basically goes and support the cell. So usually the concentration of ethanol is 50% ethanol plus 2% 𝗗𝗂𝗶. That is sarcomas fixative. Okay, so that's about fixative. I hope everybody remembered that, and everybody will remember that. So that was the last point before I leave. Okay, with that, bye bye guys. I hope the session was useful, and bye.